Okay, so for the first part of your assessment, no matter what scenario you get, you're going to be observing the patient first, and you're going to be working through active range of motion with overpressure and combined movements. So this video will work through how to do that for the lumbar spine and the cervical spine, and then we'll do a separate one for the thoracic spine. Okay, so for observation, what we want to do is spend about 90 seconds or so making sure that you're making it obvious that you're walking around the patient, looking at them from the sagittal view, the coronal view as well, so from the back and from the sides, from the front. You're directing your discussion towards the patient, so you don't want to be listing everything that you see that's different, but you do have a chance to discuss with the examiner at the end what it is that you found. So the things that you're looking for as you're walking around is different soft and bony tissue markers. So we can look at shoulder height to see if there's a difference on one side to the other. We can use the inferior angle of scapula as well to see if there's a difference in height-wise there. The PSIS on the back of the spine and the ASIS as well, we can use as bony landmarks to see whether there's any asymmetry there. Soft tissue markers, we can use things like nipple height or pec height, or any skin creases that you might see on the back or on the sides. Other things we're looking at as well is what the feet are doing and what the knees are doing. So does the patient stand in knee hyperextension? And also, very importantly, what the pelvis is doing. So is there an anterior pelvic tilt, in which case is there a lumbar lordosis, or a posterior pelvic tilt, in which case there's a hypolordosis there as well. Natural curvature of the thoracic spine, we should see a slight kyphosis. And specifically around the neck, we're looking at kind of head posture. So does the patient stand with their head in protraction or retraction? Any more prominence around kind of any of the vertical landmarks as we go through there as well. Okay, so your objective assessment should take around kind of 90 seconds to 2 minutes, just so you've got time to make sure that you're walking around the patient and showing that you're watching what you're looking for. The next stage then is the active range of motion. So if we start with cervical active range of motion, we've got rotation, side flexion, flexion extension, protraction and retraction. So for these ones, what you want to do first is observe the patient doing them. So take a step back so you can actually monitor how far they're going before you start actually recording how far you think they've gone. Okay, so first one you're going to do is have a look over your right shoulder as far as you can for me there. Good. Any problems as you get around to there? So, okay, good. Let's go back over to your left shoulder. So making sure you're asking patient questions as you go through as well, making sure there's no symptoms. Back to the centre again there. And then sideways down, so we're down towards the shoulder. Problems there at all? No. Back down the other way. Back up again. This time up towards the ceiling. Good. And then just down towards the floor there. Excellent. Back to the centre. Okay, so for protraction and retraction, the advice would be try and keep your chin level. See if you can kind of poke your chin forwards. Good. And then retraction, as if you're giving yourself a double chin. Okay, so moving on to active range of motion with overpressure. So these aren't passive ranges of motion, they're still the patient doing the full range, and then we're just assessing end range with overpressure. So you can turn to look over your shoulder again there. Okay, so this time I'm just going to push it a bit further. Any problems with do that till there? And same back around the other way. Problems that way? Okay, so again we're looking for if there's a difference between the two sides in range of motion, whether it brings on symptoms. Ear down towards your shoulder again there. Good. And again, over pressure onto that. Same down the other way. And then for flexion, just get to go down towards the floor there. Okay, so again, over pressing there just to see what the end feels like. And then up towards the ceiling for extension. And again, we can just push further from the chin. Okay, and then get to do the double chin ones, just tucking in towards you. So the third final stage of this section is to do the combined movements. So we're going to combine extensions with rotation and side flexion, flexions with rotations and side flexion. So first one, get to go down and towards your chest, and then turn to look over your shoulder. Good. And the other way. Any problems with those two movements there? No. Okay, and you're going to stay down there, but this time try and side bend your ear towards your shoulder again there. That's it. Good. Same the other way. Excellent. Okay, an extension this time is going to go up to the ceiling and then try and rotate. Good. And same the other way. Good. And then stay in extension and try and side bend. Good. Same the other way. Excellent. So they would be our active range of motions with overpressure and combined movements for the cervical spine. For the lumbar spine, the advice is that you finish with flexion. So we're going to go flexion at the end. Okay, so just going to work through those different movements you can do there as well. Just get to stand sideways on this time. Okay, so hands on your hips this time. So you can extend backwards as far as you can. So again, make sure you stand away from the patient so we've got plenty of room to observe what's happening. We're looking for if there's any obvious skin folds, so anywhere that the patient might be hinging from in particular. And come back up again. Good, hands on your hips still there, just need to go down to the side. Excellent. Again, we're asking the patient any symptoms that they might be experiencing as we go through with these tests as well. Same back up and down the other way. Good. Okay, hands across your shoulders this time. Just need to try and rotate around, but try and keep your hips pointing forwards there. Fantastic. And back around the other way. Brilliant. Good. As I say, we finish with flexions because it's the most pain-provoking often. So keep your hands on the front of your thighs there and come down towards your toes. Good. Things we're looking for with flexion there is whether the flexion is truly coming from the lumbar spine or if the patient's hinging from their hips and they're maintaining a kind of neutral lumbar position, and come back up to the top again from there. Good. Okay, we then go through those movements again with overpressure, so you need to extend backwards. And we'll just overpress at the end of range. Up. And sideways down. Providing some support with your hands just so you're not pushing the patient over when you provide the overpressure. Trying to counterbalance the pressure you're giving. And same back down towards the floor again. And we're overpressing with those movements. And come back up. And finally combining our movements, so hands on your hips again this time, so you need to extend and then side bend. Good, so this is where our clinical reasoning can come in. We're thinking about what structures it might be that we're compressing, what structures it might be that we're stressing and straining. Same the other way. Any problems there at all? No. Good. And again, extension. This time we're going to rotate. And same back around the other way. Good. And finally going into flexion. And rotating. Same the other way. And flexion, side bending. So trying to move out. Good. And same the other way. Brilliant. And back up to the top. Other things we can do within those active range of motions, we can mention the fact that we've got cervical inclinometers that we can use to get a more accurate reading. However, we're going to mainly be looking at the fact that you know that that is an option. Probably won't get you to actually perform those tests as you go through, but you will have an inclinometer in the bay as well. So for rotation, you would do in supine, flexion, extension, side flexion, you can do in standing. For the lumbar spine, similarly, it's good to have knowledge that you've got the modified Schober's test there to test true range of motion at the lumbar flexion. Again, you'll have a tape measure there present to perform that test if you have time. For that one, we're marking the dimples around the PSIS, or the back of the kind of pelvis, and then 10 centimetres above, 5 below, to get that 15 centimetre gap. As the patient then flexes, we remeasure the distance between the top and bottom mark, and that will give us a reading as to how far they flexed in centimetres.